Good afternoon, everyone, and welcome to our Summer Young Researchers Forum for the year 2022. On behalf of the CAMC Institute for Academic Medicine and WVU Charleston-based School of Medicine Division, welcome to everyone. Just a word to begin with. If you feel free to take your masks off while you're eating, or if you're in a family group, you can certainly take them off. If you should choose to exit the auditorium and go out into the main part of the building to use the restroom or even to exit the building, please put your mask back on. Thank you. I'm Mary Emmett, and I'm here today speaking on behalf of Dr. Jubilier, who was not able to be present today. Dr. Jubilier has been the leader for this forum for many, many years and was not able to be present today. We're thinking of him and appreciate all of his work and labor that he has done to make this possible today. We also want to thank Robin Rector, who has been our collaborator for many, many years and has put this program together, helped make selections of people who would come here this summer and work on the program. And so we want to thank Robin for all of that. We want to thank her staff for being here today to help us with the programming. Thank her for making sure we all had something to eat as well as drink. This forum has been going on since the year 1991. It was originally hosted by WVU, and in 2002, the Institute for Academic Medicine, or the Institute at that time, took it over. We are still doing this in collaboration with our partner, WVU, Charleston-based Division of School of Medicine. According to our records, we have had over 222 individuals come here during the summer and do a project and present it. So this is a landmark day for those of you who are here to present your information. This is an important part of your summer program. We are listening to young aspiring investigators share their lessons that they've learned during this summer experience. Today's presentation is an extension of their learning experience. It gives them an opportunity to prepare a presentation, deliver the presentation, and address any questions that you may have. So with that, we will begin our program, and thank you all very much for coming. Our first speaker today is the preceptor for our project was Dr. Stephen Jubilier. The presenter is Rosalie Hopkins from the University of Dayton, and her project title is Antithrombotic Therapy in COVID-19 Patients at CAMC.
I'm going to take this off while I talk. So hi, I'm Rosalie Hopkins, and for the last several weeks I've been working with Dr. Stephen Jubilier as my principal investigator on research into antithrombotic therapy in patients with COVID-19 at Charleston Area Medical Center. So as a little introduction, COVID-19 is an extremely contagious viral respiratory disease with cases ranging from an asymptomatic presentation, which generally does not require a stay in the hospital, to complete respiratory failure, which could require intensive ICU-level care. An acute COVID-19 infection is one that has clinical features requiring admission to an inpatient ward without intensive support. This type of infection, and worse ones, including those that do require ICU-level care, increase risk for venous thromboembolism, or VTE for short. The guidelines regarding VTE prophylaxis for COVID-19 were updated as of January 2022 by the American Society of Hematology, or the ASH. This presented us with a really excellent opportunity to evaluate our practices and compare that to the standard in the current published guidelines. So once again, in January of 2022, the guidelines were updated, and what they changed was that they now favor therapeutic intensity over prophylactic intensity when it comes to anticoagulation in COVID-19 patients. Patients that would require such a treatment include adults with low flow oxygen who do not require ICU level care, as well as adults who do require ICU level care and are on high flow oxygen. Formerly, for those individuals in particular, a prophylactic dose was recommended, and now a therapeutic dose is recommended. In most instances, low molecular weight heparin is preferred over unfractionated due to the fact that there is more adverse side effects associated with unfractionated heparin. And it is also recommended that patients undergoing anticoagulant or antiplatelet treatment continue on those therapies on admission for existing conditions following a positive COVID-19 result. Our objectives were to determine if appropriate guidelines are being followed in relation to anticoagulant use in COVID-19 patients admitted to CAMC, as well as to assess patient outcomes relative to the method of anticoagulation used, both during admission to the hospital and in the subsequent weeks after discharge. Our methods included a retrospective study of a sample of COVID-positive patients who were PCR confirmed and required admission to the hospital between February of 2022 and May of 2022. And our sample size ended up being 86 patients for this study. Factors that led to exclusion from this study include patients who received care in an ICU level setting, patients with prior or recent HIT diagnosis, patients with a BMI greater than 40, pregnant individuals, patients with acute coronary syndromes, as well as patients with chronic kidney disease at the level of the stage 5. For our data analysis, we used descriptive statistics to analyze and report our data. We used frequencies for categorical variables, means and medians for continuous variables, and our statistical software was SAS, V9.4, and CARI-NC. In terms of comorbidities, we had 0 patients that had chronic kidney disease at the level of a stage 4, but we did have 20 patients that had chronic kidney disease at the level of a stage 3. This is about 23.26% of our sample. We had 1 patient that was HIV positive, and we had 16 patients that were immunocompromised in some other way not related to HIV. We had 17 patients that had a history of heart failure, and we had 4 that had asthma. We had 39 that had a previous diagnosis of COPD, and 71 of our 86 patients had hypertension. Only 10 had active cancer. In terms of our race breakdown, our sample was primarily white, with about 95% of the sample being white. When it comes to sex, we were evenly split down the middle between males and females, each having about 50% of the sample. Our mean age for our patients was 68.58, and our median age was 69. And once again, our sample size was 86. So when it comes to anticoagulation utilization, 11 patients received a prophylactic dose of heparin, which is about 13% of our sample. 32 patients received subcutaneous heparin, which is about 39% of our sample. 25 patients received enoxaparin, better known as Lovenox in the clinical setting, which is about 29% of our sample. 6 patients received Xarelto, which is about 7% of our sample, and 25 received apixaban, which is about 28% of our sample. In terms of results, like what this means for us, 11 patients, or 13%, received IV unfractionated heparin in the absence of a thromboembolic event. This is not consistent with the current guidelines as of January 2022. 32 patients, or 37%, received subcutaneous heparin in the absence of a thromboembolic event. 7 of these patients, or 8%, received both IV and subcutaneous unfractionated heparin. And 25 patients, or 29%, received prophylactic enoxaparin or Lovenox consistent with guidelines. So that leaves us with about 35 out of 86 of our patients, or 41%, receiving unfractionated heparin in the absence of a thromboembolic event. 20 of our 86 patients had chronic kidney disease at the level of a stage 3. This leaves us with about 15 individuals receiving unfractionated heparin without any noted reason for deviation from guidelines. So what does this mean? Most current patients admitted for COVID-19 are not being admitted to the ICU, and therefore the newly published guidelines are applicable to a majority of hospitalized patients. This study indicates that we have a great opportunity for improvement in adherence to the updated 2022 COVID-19 anticoagulation guidelines, and an additional study is needed to measure the effects of any proposed education or intervention. The limitations with this study include the fact that it was a retrospective study, which means our evaluation was limited to the documentation present in the patient's medical file, which may or may not reflect all of the aspects of a clinical decision. In addition, patients on anticoagulation therapies other than unfractionated heparin or low molecular weight heparin need further review to determine if they were being treated with these drugs prior to their COVID-19 admission for other conditions such as atrial fibrillation, prior venous thromboembolism, or prior pulmonary embolism. And it's also important to look into the rationale for the utilization of both the IV unfractionated heparin and the subcutaneous unfractionated heparin, which happened in those 7 patients. Here are my references. Does anybody have any questions? I'm happy to answer them. Thank you for listening. All right, no? Okay.
Hello, our next speaker is Yibu Lin, and she has a mentor of Dr. Zachary Abarama with vascular surgery, and her topic is perioperative and clinical outcomes of transcarotid artery revascularization, a single center experience. She comes from the West Virginia School of Osteopathic Medicine. She's a second-year student.
Hi, my name is Yibu Lin. I'm a second-year student at WVSOM. I work with Dr. Zach Abirama, Dr. Eileen Davis, Dr. Scott Dean on this project. The topic of the presentation is perioperative and clinical outcome of transcarotid artery revascularization, or TCAR. Stroke occurs when there's a blockage of blood supply to the brain or a blood vessel burst. So about 87% of all stroke are ischemic stroke, and 8% of all ischemic stroke are caused by extracranial internal carotid artery stenosis. So carotid atherectomy has been used as the gold standard treatment for patients with severe carotid artery stenosis. And the carotid artery stenting has been suggested for patients with either anatomically high risk or medically high risk, or both. So anatomically high-risk patients, including patients who have high cervical lesion, patient had prior CEA, or it's radiation-induced stenosis. Medically high-risk patient, including COPD patient on oxygen therapy, severe coronary artery disease, congestive heart failure, and a recent myocardial infarction, and the renal insufficiency, serum creatinine more than 2.5, and the patient age more than 75 years. So there's a CREST trial review. There's increased risk of perioperative stroke with stenting patient, and there's increased risk of myocardial infarction with CEA patient. So TCAR came up as a new unique hybrid technique using flow reversal for neuroprotection to reduce the risk of stroke. The updated guideline, Society for Vascular Surgery note, so TCAR is the treatment of choice for high lesions. And compared with transfemoral carotid artery stenting, the overall data of TCAR demonstrate a better outcome. And TCAR may be superior to CEA and the transfemoral carotid artery stenting for high-risk patients. Here you can see on the graph, so the risk of stroke increased with an increased degree of stenosis. Studies shows when it reaches 75 degrees of stenosis, the risk of stroke increased significantly. So our study had 155 consecutive patients who had TCAR at our facilities. The objective of our study is to analyze 30-day perioperative and 1-year clinical outcome of TCAR. So LOSTER trials are multi-center, prospective, single-arm trials to assess the safety of TCAR. So we would like to compare our results to the results from LOSTER trials because they were sponsored by the industry. So retrospective analysis, and we're collecting data from 155 consecutive patients had TCAR at our facilities. So from June 2016 to May 2022, the procedure was done for high-risk patient for CEA, so including anatomically high-risk and the physiologically high-risk patients I mentioned previously, all combined. So this procedure was done by trained vascular surgeons. Variables include demographics, comorbidity conditions, symptomatic status, and in-hospital and post-discharge follow-up. Descriptive statistics were used to depict demographics, comorbidities, and outcome, specifically frequency for categorical variable, mean and median for continuous variable. And Kaplan-Meier analysis were used to estimate the survival and the freedom from stroke death and the freedom from instant restenosis, more than 50% and more than 80%. So out of 155 patients who had TCAR, we had 87% primary and 13% redo. So those patients who either had a TCAR or had transfemoral carotid artery stenting before. And the mean median age was 72, the mean follow-up time was 10.9 months. As a result, 10% patients developed instant restenosis more than 50%, and 3.4% patients had instant restenosis more than 80%. And in 94% patients had re-stenting dilatation, 25% had post-stenting dilatation. So the indication of TCAR were classified as either asymptomatic patient who had 80% or more stenosis and a symptomatic patient who had 50% or more stenosis. So out of 155 patients we had, 63% patients were asymptomatic, 17% patients had a stroke, and 21% patients had a TIA. So the top 3 comorbidities our patient had are hypertension, hyperlipidemia, and tobacco use. Other comorbidities including coronary artery disease, diabetes, and congestive heart failure. So we compare our results of 30-day post-operative complication to the original study we did last year. So all the complications have declined. So including stroke, stroke death rate, stroke death MI rate, and the major bleeding require a necessary operative exploration, and the cranial nerve injury, vagus nerve or recurrent laryngeal nerve. So we have 5.2% of major bleeding because TCAR is a relatively new procedure. So right now the guideline recommend to use protamine to reverse heparin after procedure to prevent hematoma. So in the future study, we expect to see less patients have a bleeding episode. Here's the Kaplan-Meier analysis. As you can see, 1-year freedom from instant restenosis greater or equal to 50% was 86.5%. 1-year freedom from restenosis more than 80% was 94.2%. And the 1 year freedom from stroke was 95.1%, and the 1 year freedom from stroke death rate was 94%. So in conclusion, our patient population exhibit a high frequency of hypertension, which was 91%, hyperlipidemia 85%, tobacco use 68%. Those are all major risk factors for developing carotid artery stenosis. Compared to the original study, the overall 30-day complication decreased with the addition of 53 new patients. And with additional patients and a longer follow-up on the previous 102 patients, freedom from in-stent restenosis more than 50% was 90%, and more than 80% was 96.6%. So our study demonstrated acceptable and low rate of perioperative 30-day complications. Our stroke death rate was 1.94%, stroke death MI rate was 3.23. Those results are similar to the results from LOSTER trials. And when compare our results to what has been reported for transfemoral carotid artery stenting from CREST trials, TCAR had a significant lower risk of perioperative complications. We will continue to follow our patient long-term and monitor rates of in-stent restenosis and assess our 30-day complication as we add new patients. So limitations, we are retrospective studies and we have some inherent no limitations. And we are single-center studies, so results may not be generalizable. And the long-term follow-up can be challenging in elderly populations in a rural state. Thus, healthcare professionals from different fields can help encourage our patients to continue follow-up with their carotid artery disease. Here my reference. Thank you so much for listening. Any questions?
Those are encouraging results, I guess, comparing to the national statistics. It looks like when you were comparing the earlier subset of patients to the existing ones, did you look a little bit at the comorbidities? Were they similar populations when you did that comparison, or was it just a rudimentary kind of a drop in, take a look at what happened before and after? Or did you look at other things that may have influenced on the outcomes?
These are, I think, really similar populations. Like in our study, and those patients usually have comorbidity are really similar because these are all like major risk factors for TCARs. Okay.
So you did do formal analysis of that, it sounds like?
I think we did like comorbidity and the demographics and patient age and like post-operative like complication and the long-term like that we focus on.
And then some of the follow-up, were they clinically driven outcomes? The 10-month outcomes, is that what you look at, 10 months out?
As you can see, the Kaplan analysis, the number it's until like 2 years. But right now, the follow-up time, the average is 10.9 months.
And as far as the follow-up on that
average time.
The majority of those people followed up in the clinic, you had ION, or the majority, were there a few of them maybe that didn't follow up in our clinics?
Right, it is hard to follow up in elderly population. So we average, our patients follow-up is 10.9, but this data we can see, the freedom from stroke until 2 years. Thank you. Elaine, you have a question?
I just wanted to know, you had quite a lot of activity that you did as part of this. It was kind of related to it. What would you say was the thing that you learned, and what was your best learning experience, just for our interest? What was the best thing that you picked up from this?
Luckily, I got a chance to observe the TCAR procedure, so I can talk a little bit about it. So it's basically, it's the vascular surgeon make a small incision at the proximal carotid artery and they use arterial sheaths to connect to the neuroprotection system and then direct the blood flow away from the brain. And from there, the neuroprotection system has been established with flow reversal to the common femoral vein, so create an arterial vein shunt. So in that way, there's a fragments of the plaque was released during stent insertion. So instead of going to the brain causing stroke, it will get filtered in the neuroprotection system. I think I really enjoyed the experience here. Any other questions? Okay. Thank you, everyone. Sorry.
putting it on, yeah. Okay, our next speaker is Audrey Gregor, and she is with Marshall University, and her topic is a methodology for co-registration of coronary artery calcium scan and contrasted enhanced CCTA. Her mentor is Dr. Sarah Reinhart from cardiology. We're going to have you hold it because we know that you can probably hear better. Okay.
Okay, hello. My name is Audrey Gregor, and my principal investigator was Dr. Reinhart, and my research coordinator was Frank Annie. And we did our research on a methodology for co-registration of coronary artery calcium scan with contrast-enhanced CCTA. And so before getting into my study, I first want to talk about what is coronary artery disease. And it's when calcium builds up in the arteries of the heart and blocks blood flow to the heart, and it prevents the heart from getting enough blood, oxygen, and nutrients. And so some symptoms that patients experience are chest pains, shortness of breath, heart attack, nausea, weakness, lightheadedness, and pain or discomfort in the arms or shoulders. And so there's different methods, such as CT scans or left heart catheterization, that can determine whether a patient has coronary artery disease. And then there's other modalities, such as FFR, Ivis, and heart flow, which are used to determine whether the blockages are significant enough to cause symptoms. And the reason why we do these tests is to determine accurately whether a patient is required to have a stent placement to unblock the arteries that have built up with plaque. And the more accurate the test, the better outcome there is for the patient. And so my study is going over whether heart flow provides better patient outcomes with less downstream testing compared to traditional methods. And so I first want to talk about the traditional methods that are commonly used. And so we first have CT scans. And so a CT machine produces images of the heart and its blood vessels. And some advantages is that it is non-invasive. It has a detailed image of the bone, soft tissue, and blood vessels all at the same time. And some limitations is that there is low pixelation, and it can provide an inaccurate calcium score. It also produces an ionizing radiation, which could damage the DNA. And also, the patient is given a contrasting material to ingest, and it can cause medical problems or an allergic reaction. And so those are some things to consider. And as you can see on the image on the right, it's a scan of this, it's a CT scan, and you can see that the white is like a calcium buildup. And I'll go over the score quickly. So the more calcium there is, then the higher the calcium score you have. And so it goes from 0 to over 400. And so 0 shows no evidence of coronary artery disease, and then over 400 shows like an extensive evidence of coronary artery disease, and then there's a middle ground too. And then another traditional method is invasive FFR, and it determines the ratio between the maximum achievable blood flow in a diseased coronary artery and the theoretical maximum flow in a normal coronary artery. And FFR goes from 0 to 1, and an FFR of greater than 0.8 demonstrates that blockage should not cause symptoms or require intervention. And some advantages is that it's a precise quantification of the degree of myocardial ischemia, and it's useful for intermediate or angiographically ambiguous lesions when there are no non-invasive functional studies. And then some limitations is that it is invasive and requires a vasodilator such as adenosine. And also FFR can be artificially elevated leading to underestimation of lesion severity. And so how you do FFR, as you can see on the image on the right, you take the distal pressure and you divide it by the proximal pressure, and that will give you an FFR score. And from there, you can determine whether or not there's blockage and whether or not it requires intervention. And then you also have the Ivis test, which is another traditional method, and it is a catheter-based diagnostic procedure that uses sound waves to see inside blood vessels, and it is used to measure the plaque buildup in the coronary artery. And the Ivis value is from 0 to 4, and an Ivis of greater than 1.5 means that there is stenosis. And so the advantages is that it has greater spatial resolution. It has details such as lesion length, eccentricity, calcification, thrombus, necrotic cores, dissections, and stent apposition and expansion are easily visualized. And some limitations is that it is invasive and it's difficult to interpret. So as you can see on the right, after they do a catheterization and put the, when they do the catheterization and they look inside the coronary artery vessel and see that there's plaque buildup. So that is how it's done. And now there's this new method called heart flow, and it uses data captured by CT scans, and it generates a 3D model of a patient's heart. And the advantages is that it has a better edge detection, provides better resolution, it's more accurate, higher diagnostic performance compared to other non-invasive cardiac tests, and it's more detailed view of the significance of the coronary artery blockage than a standard coronary CT scan, and it's also non-invasive. Some limitations is that this is new technology, and it requires a contract with a company and additional costs, but without additional procedure. And also, it's dependent on the quality of the CT scan. And so, an FFR of greater than or equal to 0.8 is consistent with no lesion-specific ischemia, and it's treated medically. An FFR of 0.75 to 0.8 is a gray zone area, and it's designed as a buffer to not miss significant blockages. An FFR of less than 0.75 is a lesion-specific ischemia and likely requires intervention. And then an FFR of less than or equal to 0.8 is considered appropriate to send to cath labs for further evaluation. And so as you can see on the right, this is how a heart flow, it's actually really cool because it's 3D and you can actually move it around, and you can determine blockages in the actual coronary artery valves, which is really, really interesting. And so for methods, I did a retrospective cohort study using CAMC data warehouse from January 1st, 2019 to January 13th, 2022. And my inclusion criteria were patients 18 to 90 years old and patients with CT of the coronary artery and FFR and no heart flow and or use of heart flow. And then my exclusion criteria were patients less than 18 years old. And my sample size was 3,220 patients. And then also I did a propensity score match, which matched the cohorts with my covariance, which consisted of age, female, male, diabetes, coronary artery disease, heart failure, history of smoking, chronic obstructive pulmonary disease. And my outcomes was 1 year rate of mortality, 1 year rate of heart attack, 1 year rate of stent placement. And so this is the baseline characteristics of my control group and my observatory group. And as you can see here, the CT and FFR and no heart flow is my control group, which consists of 2,760 patients. And then my observatory group was the CT and FFR and heart flow, which consisted of 460 patients, and that's on the left. And if you look, we could see that there was a slight increase in the amount of males and diabetes and coronary artery disease, heart failure, history of smoking, and chronic obstructive pulmonary disease for the observatory group. And then we did a propensity match cohort to do like a one-on-one to make sure that we didn't have any variables that could have like affected the data. And so by doing a one-to-one of the control and observatory group, we could see that they are more in line with one another and are a lot closer. And so then for my results, so a result at 1 year for FFR heart flow versus FFR no heart flow. For mortality, we saw that there was a 2.1% of FFR heart flow to a 2.1% of FFR no heart flow, and the p-value was equal to 1, which means that this was not significant. And then for heart attacks, we could see that for FFR heart flow is 2.1% to 4.3% for FFR no heart flow, and the p-value was 0.06, which showed that heart flow has a 50% reduction in heart attacks at 1 year. And for stent placement, we saw that FFR heart flow was at 17.3%, and for FFR no heart flow, it was at 10.8%. And the p-value was 0.01, and it shows that heart flow had a 60% higher rate of stent placement versus traditional methods. And on the right is my Kaplan-Meiers, which is evidence for my results. And also, we could see that there is a significant difference for heart attacks and for stent placement for FFR heart flow. And so for my conclusion from my results, where heart flow had 50% reduction in heart attacks at 1 year, and heart flow has a 60% higher rate of stent placement versus traditional methods, we can see that heart flow appears to be a new novel method of imaging that will help with early diagnosis and treatment of certain cardiac conditions. And also for the future, mortality might shift slower after more clinical trials are done. And these are my references, and thank you. Any questions? Yeah.
I have a question.
Yeah.
So one is more specific or more sensitive than the other one?
Yes, they're both, heart flow is more specific and more sensitive compared to the traditional methods. Yeah. Yeah.
Is there any one of the traditional methods that's like the preferred main standard method?
I would assume, I shadow Dr. Reinhardt, and they tend to use CT scans because that actually determines coronary artery disease. And then the other tests tend to just determine whether or not it's significant for coronary artery disease. So they're kind of like extra tests that are done to make sure the information is like correct. So I'd say currently CT scans are. And the thing is that with heart flow consists of CT scans along with this algorithm that makes it more accurate for determining coronary artery disease. So it does use CT scans with it, so yeah. Sorry.
I really appreciate the review of all the modalities. That was great.
Thank you.
As you thought about your confounders, which I like the propensity score matching that you did too, were there other variables that may have been involved in driving why the clinician decided to do the heart flow versus not, that may have influenced your results?
I mean, currently, this is what we found to potentially, these baseline characteristics are the ones that we found to actually potentially affect the heart flow data, but I mean, obviously there probably is more that we haven't accounted for yet or haven't seen, but that's definitely something that we will look more into to make sure that our data is accurate. But yeah, thank you. I mean, we'll definitely look out for any other characteristics that might affect the the results. Thank you.
I have a question about mortality. Was your mortality percent based on information that you found in the record as far as patients who had expired at CAMC, or did it include any mortality from outside?
So it include mortality from, I believe, CAMC, since this is a retrospective study. And so when I did my data collecting, I did it from the CAMC server. So yes, I believe currently all our data that we have collected is based just on CAMC. So yeah, I would say this wouldn't be the best representation of just like a generalized overview of if heart flow is, better, but that's why I'm hoping that in the future more research can be done in other hospital areas to see if there's like other, if they see the same trend going on.
That's a very challenging variable for many studies.
Yeah,
Very, very challenging.
yeah. Any other questions? Okay, thank you. Five? F5. Can you help me? I'm sorry.
Okay, our next speaker is is Sohail Gopal, and he is a second-year medical student at the West Virginia School of Osteopathic Medicine. His topic is virtual group-based parent training for child ADHD and externalizing behaviors, the effects on core problem behaviors, parenting stress, and parenting efficacy. And his mentor is Dr. Chanel Weissenmuller.
All right. Hello, I'm Sohail Gopal. I'm a second-year osteopathic medical student, and I'll be presenting on accounting for ODD symptoms in ADHD children to improve engagement in group-based behavioral parent training. I'd like to thank Dr. Weissenmuller, Dr. Hilton, and Ms. Calderwood for having me on this project. So first, a quick background on the disorders that I'm going to go over. So attention deficit hyperactivity disorder. This is in patients who have difficulty maintaining focus and have episodes of overactivity. This disorder has a high prevalence around the world, and in America it has been estimated to be in about 6.1 million children. The second disorder we're looking at is oppositional defiant disorder, or ODD. It is normal for children to oppose authoritative figures such as their parents or teachers, but if it is something that is consistent for at least 6 months, they might have this disorder. And then the third disorder, conduct disorder, or CD, that is more seen in older children or teenagers, usually stems from uncontrolled symptoms of ADHD or ODD. And these can really relate to each other, as having one can increase your chances of having the other. For example, having ADHD does increase chances of having symptoms or even being diagnosed with ODD. And here's just a flow chart of how these disorders can relate to each other and share some symptomatology. So in order to prevent someone to have CD, we do want to treat their ADHD or ODD as soon as possible. So the treatment options for those is to first look for a therapy intervention that could work out. The one that I'm going to be focusing on is behavioral parent training. And there are also other options such as cognitive behavioral therapy and support group that has shown great results. If the therapy is not working well enough, there are pharmacological options. The gold standard is psychostimulants, and it is methylphenidate that is usually prescribed. And of course, if that doesn't work well, there are other medications that have worked well, such as alpha-2 agonists and antidepressants. And I also want to talk a little bit about multimodal, which is just a combination of a form of therapy and a medication, which has the additive effect of not only decreasing symptoms, but also improving social skills and enhancing relationships. So behavioral parent training, or BPT, is usually an 8 to 16 week intervention, and it can be on an individual basis or group basis. When it comes to group-based intervention, that is being more popular because it is more efficient, and there's the added benefit of creating a social support group with the parents. And at the end of this intervention, the main goal is for the family dynamic to improve and have a more better communication style with each other, having a less stressed environment, and parents have even expressed how much their confidence has increased and they've noticed less misbehavior from their child. But this therapy does have a lot of challenges. So a lot of past studies have addressed how important it is for the parents' engagement in order to get the most out of this. And this therapy is also quite scarce in many communities, usually those that are disadvantaged or underserved. And a lot of past research have also shown that there tends to be an overrepresentation of non-disadvantaged families in this therapy and even in the studies. And usually these studies also tend to exclude addressing ODD symptoms or even have it within their exclusion criteria to not have the patients who have tendency for aggressive behaviors. So before the COVID-19 pandemic, Dr. Weisenmuller's team did conduct a study to focus on disadvantaged families and focus on the West Virginia population. What the team did was condense BPT into a 6-week course so that it can decrease the barriers that tend to come for those who are in rural communities. The study did have small to moderate positive effect, but there was still that challenge of engagement decreasing over time with this intervention. So that is what I'm going to be addressing. And what I hypothesized was there were some factors that we can address that could be affecting the engagement. That could be the level of parenting stress or efficacy, and the child's symptom severity in ADHD or ODD before even starting the intervention. So this study was able to get its participants from local West Virginia psychiatric clinics, and those who qualified for the study had to dedicate 14 weeks. 1 month was dedicated to the screening process and a meeting before starting the intervention to get a good understanding of the expectations out of the course. And then it is a 6-week-long intervention, and then after a month, there's a follow-up to see the long-term outcomes. When being screened, the inclusion criteria, of course, had to be the patient needed to be diagnosed with ADHD, and the age range that we kept was 5 to 12 years old, and the patient also had to be an active patient. And here are exclusion criteria. The patient, those who were excluded had autism spectrum disorder or any intellectual disability. And they were also excluded if a patient or their parent had any psychosis or substance use disorder. When it came to our data analysis, we used SPSS to see the correlation of our variables of interest with engagement. When it came to our variables of interest, we extracted that from the surveys we had the parents fill out along with the intervention. These variables included symptom severity of the child, which was assessed using the Vanderbilt ADHD Diagnostic Parent Rating Scale, which covered symptom severity of ADHD, ODD, anxiety, and depression. In that survey, we also included the parenting stress scale. And for parenting efficacy, there were 2 scales that were used to assess that: the parenting sense of competency to assess for self-esteem, and parent self-agency for confidence in their parenting ability. And these were the variables that we compared to their weekly attendance as a form of measuring their engagement. So looking at the results, this first table is just looking at a simple distribution of our variables of interest. Since there were 19 participants who came to our pre-treatment meeting before starting the intervention, that was our sample size for most of our variables. Our one variable, self-agency, had 18 as the sample size because one participant unfortunately did not complete that part of the survey. So the first analysis that we did was a bivariate correlation, and the correlation that stands out the most to us is how ODD symptoms compare to the attendance. That was the only significant correlation, and since it is negative, from that we know that if a child already had high severity of ODD symptoms, the parent is most likely to decrease their attendance in the course of the intervention. These next tables are our t-test. To break it down, what we were comparing was high engagement versus low engagement. We said that high engagement meant that they attended more than half, meaning more than 3 sessions, and those that were low engagement were half or less. And first looking at the effect size using Cohen's d, the two variables that stand out to us are parenting stress and ODD symptoms. And here's just a simple breakdown of what that means. And in the discussion, I'll be breaking down what are some perspectives we can take from this. The bottom table is our t-test, and the one variable that, based on our p-value, stands out is ODD symptoms. So this again just shows the high correlation, despite our small sample size, of the severity of ODD symptoms to the level of engagement from the parents. So this study was focused on disadvantaged families, and the reason why we condensed the intervention was to decrease as many barriers as possible, and there was great effect. But we need to focus on improving engagement, as that is one of the biggest factor of getting the most out of this intervention. So based on our results, we can already see that the level of ODD symptoms is highly correlated to how engaged a parent is going to be, and even parenting stress can be a little related based on the effect size. One thing that we can get out of this, and based on other studies we also know, is parenting stress in itself is dependent on a lot of variables, especially when it comes to their child's symptoms of any psychiatric disorders. So from that, providers and future providers can get out of what type of expectations they want the parents to understand before they move forward with this therapy. They need to be able to understand what are the short-term goals and long-term goals. When it comes to BPT, we are introducing effective use of reward and punishment for the child. So if the parent is introducing this new form of discipline, then the child's emotions are definitely going to be exacerbated, which can lead to parents dropping out of this and going back to the way things were. So this is just an understanding that we can have, and something outside of this study, we can also look at other barriers that disadvantaged families and even any other families around the world can face, which is transportation, childcare that they need while they're doing these courses, the COVID-19 pandemic restrictions that we have now, and mental health stigma that can exist within family or the community that can affect what treatment options they want to move forward with. When it comes to the study's limitation, the biggest limitation was our sample size. The study did need to be cut short due to the COVID-19 pandemic, and we can see that despite 39 eligible participants being identified, when it came to just coming to the pre-group meeting before starting the intervention, 20 people dropped out. So something to look forward to for future research, since we are in this pandemic era. We have moved forward with getting IRB approval for a virtual option. So that is going to be decreasing a lot of the barriers that were discussed before. and hopefully there will be more participants when it comes to this. Depending on the sample size, we could even look at other variables to assess for getting more engagement and getting better positive outcomes. We could even break down the courses and see if the 6-week condensed program is really as effective as it is efficient. With future research, we can also identify if there are any other limitations that exist with this therapy, and that could be added to the proper expectations we want parents to have with moving forward with this. And also, depending on the diversity of our sample size, we could add in other variables such as guardians relations, as there are some grandparents or foster parents who participate in this. We could even address, which has been quite a challenge in the mental health world, is how to address stigma that exists, and see also within the community what are the child care options that parents tend to go to when they want to participate in this. And the end message of my study was essentially for providers to understand what are the expectations parents should have when they're moving forward with BPT, especially if their child does have ODD along with ADHD. And here are my references. Thank you so much for listening. Are there any questions?
I have a question.
Yes.
So, just to be clear, nice presentation. The demographics of the parents, were all the children represented by a father and a mother? Was that who came to the therapy, or was it just the mother, or just the father, or was that, was the relationship there with the engagement as well?
Right. So most of the time, in this study, most of the participants were mothers, but there were some fathers that came also. Usually just one parent comes to this. Even in previous studies, the population within this therapy does tend to be more mothers than fathers. Yes.
So they're permitted to have both parents attend the session if they choose, as long as they have one parent consistently attend, and it can be either person.
So is there less engagement by the male parent than the female parent?
Yes, there's more female engagement, even if it's a grandmother.
So that would be another place to try to enhance the program. Also with the high ODD score and recognizing that, I guess, those patients, those groups dropped out, is there any consideration or thought that you guys put into maybe considering pharmacological therapy or a shorter time course with that population?
Um,
I'm not sure how acute the problem is, but it looks like it doesn't work in that population. Would it make you think pharmacotherapy in a shorter time period?
Right, that is like a future study that can be more looked into. Yeah, especially those who have ODD, maybe the pharmacological option can be introduced earlier in their therapy. Is there anything you want to add, Ms. Calderwood?
So you looked at variables that contributed to the decreased engagement over time. Did you look at any variables that contributed to the significant initial dropout, which you mentioned you started with 30 plus and then 39 and around 20?
Right, the thing is that once someone drops out before starting the intervention, we can't use them anymore as a participant, so we can't look at those variables. It would be interesting to look at that, but it was just something we didn't have access to because of that.
Do you think you could maybe utilize some form of survey to maybe look at maybe socioeconomic status? Or you also mentioned transportation was a big one.
Right, like the whole goal of this study and even moving forward is to mainly focus on those who come from a low-income background. And this study, most of the participants were from that. So we can even look at the fact that a lot of them who dropped out, they also were from a low income and they had these barriers of transportation, which is why when moving forward with the virtual options, that is hopefully one variable that gets canceled out and we can look at other barriers that exist.
Sorry, question. When you say active patients, what do you mean by active patients? They were already being treated?
Right, yeah, they were already in a psychiatric clinic being treated.
Did you look at how they were diagnosed? Because sometimes a lot of patients are misdiagnosed with autism, ADHD. Did you look at how they were diagnosed at all, or you didn't?
I didn't. Ms. Calderwood, was anyone else in the team able to?
So they were diagnosed by someone at the behavioral medicine department or the behavioral specialist at PEDS. So someone, a provider within CAMC. But do you guys know how they were? Because sometimes they would not be diagnosed by a private outside provider, because then that would be more potential like most frequent misdiagnosis may occur from a referral at that point. Yes. That was it. Thank you.
Yeah, thank you so much.
Okay, our next presenter is Zayed Al-Asadi, and he is a second-year medical student at the West Virginia School of Osteopathic Medicine, and his topic is clinical outcomes with Lenesolid use in the non-pregnant adult patient with recreational drug use who have MRSA native valve endocarditis compared to patients who receive the standard of care. And his mentor was Dr. Mandotti.
Good afternoon, everyone. My name is Zaid Al-Asadi, and today I will be giving a presentation on MRSA native valve endocarditis, specifically in the patient population of recreational IV drug users. The title of the project that we've been working on is Clinical Outcomes with Lenesolid Use in Non-Pregnant Adult Patients with Recreational Drug Use who have MRSA native valve endocarditis compared to patients who receive standard of care. Now, due to the limitations of this study that we've been dealing with, we have yet to get final results and data analysis on this, so I'll be focusing more on the clinical aspect and science surrounding this subject. So I want to first talk about the epidemic of recreational drug use and where we're at today. So here's a graph published by the CDC that shows the trend of drug-involved overdose deaths from the year 1999 to the year 2020. And as you can see, in the year 1999, there were just under 20,000 deaths, with that number jumping up to roughly 92,000 in the year 2020. So that's about a five-fold increase in the span of 20 years. Despite efforts to really tackle this problem, such as decreasing the amount of abusable drugs prescribed by physicians, as well as implementing drug addiction programs throughout the country, we really have yet to flatten this curve. And in fact, on November 17th, 2021, the CDC released provisional data on this and showed that the drug-involved overdose deaths topped 100,000 for the first time ever. Now, it's important to not only think about how this subject relates to the drug users themselves, but how it affects our society as a whole. And some of the downstream effects include the increase in incidence in fetal abstinence syndrome, which is when a child undergoes withdrawal symptoms from a drug that they were exposed to in the womb, loss of productivity in society from the drug users themselves, direct and indirect cost on the healthcare system, direct and indirect cost on the criminal system, and lastly, the problem of infectious diseases such as hepatitis B, hepatitis C, HIV, and endocarditis caused by MRSA infection. I want to shift gears a little bit and talk about what is endocarditis, what are the causes of endocarditis, and how we can treat it. But before I do that, I think it's a good idea to get a good understanding of the heart anatomy to get a good understanding of this pathology. So without going into too much detail, you can think of the heart as having two main layers separated by potential space, with both layers being further subdivided into even more layers. So the most external layer is referred to as the pericardium, and that's anatomically divided into the fibrous pericardium and the serous pericardium. Going deeper to that, we have that potential space I just mentioned, and then going even deeper, we have the heart wall, which is further subdivided into the epicardium, the myocardium, and the most internal layer being the endocardium. And it's this most internal endocardial layer that becomes inflamed when we have a patient diagnosed with endocarditis. So what is endocarditis? Again, it's inflammation of that most internal endocardial layer that really can be caused by a multitude of things. The most common cause is a bacterial infection that originated somewhere else in the body and then spread to the heart via the vascular system. And so the bacteria get to the heart, it deposits on the endocardial layer, as well as the heart valves themselves. And it's this association of the heart valves with this pathology that makes it so dangerous. An in-depth review that was published actually by the American Heart Association showed the different complications associated with endocarditis and their frequencies. So here I provide a graph with the more common ones. And you can see just under 20% of patients will experience congestive heart failure, so about 1 in 5. 63% of patients will have periannular abscess. 36% will have a systemic embolization, which can be very, very dangerous. And roughly 30% will have a neurological complication. So there are different things that can put people at higher risk of acquiring endocarditis. A patient that presents with an acquired valve disease, such as mitral valve prolapse, is at higher risk. Patients with an artificial heart valve as well, or even a heart device such as a pacemaker, is at higher risk because the bacteria actually grow more efficiently on those materials. Patients with suppressed immune systems, we found that males are twice as likely than females to get endocarditis. Patients that have poor dental health are at increased risk because the bacteria in the oral cavity can undergo that hematogenous spread that I mentioned before. Long-term catheter use, older age, and IV drug users. So when attempting to make a diagnosis of endocarditis, the gold standard set of guidelines is something referred to as Duke's criteria. And Duke's criteria can be split into 3 different types of criteria: pathologic, major, and minor. And so to make a confirmatory diagnosis, you need one of 4 different combinations. The first combination would be if the patient presented with 1 positive pathological criteria. So either the presence of a microorganism demonstrated by culture on a vegetation, or a pathological lesion confirmed by a histoexam. A second combination would be if the patient presented with 2 positive major criteria. So they would need 2 positive blood cultures taken 12 hours apart, in addition to evidence of endocardial involvement as seen by a positive echo, for example. And then if the patient only presented with 1 positive major criteria, they would need an additional 3 positive minor criteria. And I'll get into some of those clinical symptoms on the next slide. And then lastly, if the patient didn't have pathologic or major criteria, they would need all 5 positive minor criteria to have a confirmatory diagnosis. So blood work and medical imaging are really important in making a diagnosis, but it's just as important to consider the patient's clinical symptoms and take a thorough medical history as well. So patients can present with a fever above 100. It's common to see sweats, chills, petechiae spread throughout the skin. It's also common to see shortness of breath or a persistent cough. But the problem with these clinical symptoms is that they're not so specific to this pathology. Some of these symptoms resemble symptoms of the flu, for example. So that's where the thorough medical history comes into play. So for example, if you have a patient that's a known IV drug user that presents with these symptoms, then endocarditis should be high on your differential. And then you'd want to order blood work and have a Trans-Esophageal Echocardiogram done as well. So a Trans-Esophageal Echocardiogram, or a TEE, is actually the most important tool in making a confirmatory diagnosis. This is a procedure that's usually done by a cardiologist where the ultrasound probe is placed down the patient's esophagus and imaging of the heart is obtained that way, as compared to a TTE, where the ultrasound probe is placed directly on the patient's chest or abdominal wall. So here I'm going to show you a TEE of a patient with mitral valve endocarditis and kind of go through it with you guys. So on the bottom of the picture, we have the left ventricle, and then on the top, we have the left atrium, and the mitral valve is in between, kind of allowing the blood to go from the atrium to the ventricle. And then here I'm circling that bacterial vegetation that you can see on the TEE on one of the leaflets of the mitral valve flopping around in that cavity. So when you see this on TEE, taking into account blood work and medical imaging, it'd be confirmatory of a diagnosis. So I want to shift gears and talk about the microbiology and how we can treat it. And here I provide a list of different bacteria that can cause endocarditis. And it's important to know the different bacteria because each bacteria kind of causes a different clinical presentation. But the one I highlighted is Staphylococcus aureus, which is the one we focused on in our study. So Staph aureus is a gram-positive cocci that forms grape-like clusters in culture. It's catalase positive, which differentiates Staphylococcus bacterial group from the Streptococcus group. And it's also coagulase positive, which further differentiates Staphylococcus aureus specifically from other bacteria within the Staphylococcus genus, such as Staph epidermidis, for example. So Staph aureus is the major cause of acute endocarditis. It's the most common cause in IV drug users. The infection is usually very severe with symptoms coming on very rapidly, usually appearing only within a few days. Patients can present with tachycardia, hypotension, and severe respiratory response that can be due to sepsis or septic shock. And compared to the other bacteria that I mentioned before, Staph aureus is highly virulent, meaning that it can infect patients even with normal and healthy heart valves, making it that much more dangerous. So what are we focusing on in our study? We're attempting to compare the current standard of care to the use of an oral antibiotic instead. So currently, intravenous antibiotics are first-line treatment, and the American Heart Association, as well as the American College of Cardiology, they recommend IV vancomycin specifically for 6 weeks. Vancomycin is really attractive because it has great activity against MRSA infections, and it's also an antibiotic that's bactericidal, meaning that it has the ability to kill the bacteria instead of just suppress its further growth, as seen in other bacteria that are considered bacteriostatic, like Lenesolid. So IV Vanco actually performs pretty well in most situations, but it doesn't come without its complications in this specific patient population. A recent study that came out of North Carolina showed that 42% of hospitalized drug users are uninsured or have Medicaid coverage. So this kind of is demonstrating that there is a financial burden not only on the hospital system itself, but also on the patients themselves as well. And there was a study done here at CAMC by Dr. Bates that showed that endocarditis admissions increased from 26 patients in 2008 to 66 admissions in 2015, with only 22% of total hospital charges being collected. So kind of further demonstrating that financial burden that this patient population has on the hospital system. But really, I like to think of this as kind of having like a two-pronged problem, with the first prong being that we can't administer IV Vanco, or we can't discharge these patients with IV vancomycin because by nature it requires IV administration, and most centers don't allow this patient population to be discharged with a drug that requires IV administration due to fear of manipulation of the IV lines at home for the purpose of drug use. The second prong is that IV drug users are at a 2 to 4-fold increase in tendency to leave against medical advice compared to their non-IV drug use counterparts. So putting them at increased risk for readmissions, morbidity, and mortality. So we can't discharge these patients with this medication. Oops, sorry. And then at the same time, they're leaving before the 6-week course is over. So they're coming back, and it's a big problem. So how do we tackle this problem? A lot of infectious disease physicians here in southern West Virginia have been using oral Lenesolid as an alternative. And Lenesolid is an attractive alternative option because It also has great MRSA activity, but it's also 100% bioavailable, meaning that we can discharge these patients on the oral form, even though it is bacteriostatic and not bactericidal. And the need for this study really comes because there's a big gap in the literature that doesn't show how Lenesolid performs in these situations and the outcomes of patients using Lenesolid instead of IV Vanco. So we're hoping to see that by comparing these two different antibiotics, we can demonstrate that Lenesolid can be a safe alternative, reducing the length of stay at the hospital and further reducing the healthcare cost. And these are my references. Any questions? Yep.
You mentioned a lot of patients don't have or have financial problems.
Mm-hmm.
Lenesolid's a really expensive drug, so how are they addressing that?
Yeah, so I talked to Dr. Mandati about that as well, and it seems because Lenesolid is being used off-label, a lot of their insurances aren't covering it, so that's also a problem as well. It's not perfect, but the current standard of care doesn't work nearly as well for this specific patient population. So we're hoping that by producing more studies with Lenesolid, that maybe it'll become a standard of care and covered by insurance.
Yes, comparing the cost of keeping a patient in a hospital bed on IV vancomycin as compared to perhaps the outpatient cost, even if the hospital has to contribute to that, is probably a very motivating factor. It's still remarkably less than trying to maintain that patient in the hospital for the entire 6 weeks.
Yeah.
There have been some, I don't know if you've been exposed to it yet, there are some experiments with multidisciplinary teams around patients who come in with endocarditis. And typically they're just treated and have open heart surgery, have their valve replaced, and get on their way, either with their IV bank. And we don't really address all the problems that maybe brought them here in the first place. And then the result is that they come back, they send themselves out AMA, they return to the community, and the IV drug use problem has not really been addressed well enough. There's some things going on with that we haven't really tackled here, and I think that this oral alternative would definitely be part of it.
Thank you.
Did Dr. Mandati go over any of that with you? They haven't really come to any conclusions about what to do.
Yeah, not yet. With this specific study, what's the biggest limitation that we're having is that it's hard to get follow-up information from this patient population because, frankly, a lot of them are homeless. And then on top of that, whenever they do follow up, we don't have access to it on the CAMC EMR. So we have to try to call the doctor's offices. It's really early on in the study, but we're hoping to kind of get around that at some point. So,
Very challenging.
yeah. Any other questions? Thank you.
Okay, our next speaker is, pronounce that for me. No, Maria Mace, and her, I'm sorry, she's a second-year medical student at the West Virginia School of Osteopathic Medicine, and her topic is the effect of Dexmatomidine, I'm trying, on delirium in the trauma ICU patients. That's a hard one to do. I would have to practice that one. And her mentors are Dr. Holmesy and Dr. Kafta.
Thank you. All righty, everybody. I talk with my hands, so if the mic one's away from me, if anyone wants to raise their hand and let me know to calm down, it'll be great. But so hello, thank you all for being here and listening to my presentation, as well as the colleagues that came before and will come after me. I am Maria Mace. I'm a second-year student at the West Virginia School of Osteopathic Medicine, and for the last few weeks, I've been working with Dr. Homsey, Dr. Kafka, as well as Ms. Dee Samanta and Ms. Melda Brown in the Trauma Research Department to look at the effect of dexmetomidine on delirium in trauma ICU patients. So I want to start off here talking a little bit about dexmetomidine. In the clinical setting, it's also known as Precedex. It is a selective alpha-2 agonist, which is used clinically for short-term sedation, pain management, and prophylactic myocardial ischemia treatment. And then, of course, for this study, the clinical usage of interest is that short-term sedation, specifically in ICU patients. It is very well used, and it's preferred by some physicians because of its short-term and light sedation, which can allow for patient arousal if needed. However, when using dexmetomidine for some patients, there is transient decreases in heart rate and blood pressure, which can prove a little difficult to use it in certain patient populations. So I had mentioned that it's a selective alpha-2 agonist, and for anyone who might not know what that means clinically, so in our body we have our autonomic nervous system. It's divided into sympathetic and parasympathetic, and think of a moment where you may have gotten scared or were fearful of something. Don't scare yourself too much, but if you think of that moment, that is your sympathetic nervous system kicking on. So your heart rate might increase, you might get a little sweaty, a little nervous. Those are all responses of your sympathetic nervous system. So within your sympathetic, you have your alpha and your beta receptors. So our alpha-2 adrenergic receptors are actually inhibiting receptors when they are stimulated for your sympathetic nervous system. So what happens here, I don't know if I have a pointer or not, but whenever we administer dexmetomidine, it prevents the release of norepinephrine here from our synaptic vesicle. That release is going to prevent your sympathetics from kicking on. So in short, I have some simplified figures over here. This is what should happen normally when there is no alpha receptor stimulation. And then this is a more sophisticated figure. And then over here as well, the simplified version, just demonstrating that we have that prevention of norepi release. So, and then just in words here, what's happening is whenever we have the binding to our receptor, it is a G-alpha I, G protein coupled receptor. That stimulation is going to decrease our cyclic AMP, which is also going to lead to a reduction in pKa and calcium. Those physiological effects result in a decrease in heart rate, vasodilation, diuresis, sedation, which is our important one here for this study, as well as some pain relief, nausea, and hypoxia. So we're going to switch gears a little bit. We talked about the drug. Now we want to talk about what's happening with our patients. So emergence delirium. Delirium is a very common consequence actually following any sort of anesthetic or sedation. Patients who develop delirium are going to be at a higher risk of longer lengths of stay and poor outcomes. A bit of a personal story that I have here, I used to work at Mon General in Morgantown, and while I was there, I had the opportunity to shadow with a general surgeon. He had a patient, went through a procedure, everything was fine, post-op checkup was great, he was getting discharged, and the paperwork went to go in, and this patient was in a complete state of delirium. So he was going to be discharged after 2 days, and I believe the patient stayed in the hospital for longer than 2 weeks because of the state of delirium. It's very devastating for the patient as well as the families, because once that happens, there generally isn't a quick fix or anything for it. So not only is it very cost devastating, but psychosocially very devastating for the patient and their family as well. So studies have found that the risk for delirium will increase if the patient had been given or any exposure at home to benzodiazepines like lorazepam or midazolam. And then the few studies that I have down here reference dexmetomidine specifically, and that dexmetomidine compared to Versed, patients had a significantly lower risk of developing delirium in a shorter duration, as well as comparing dexmetomidine to lorazepam under mechanical ventilation. The dexmetomidine group had a shorter coma duration and shorter delirium durations. And then this word agitation is mentioned in this last study, and that'll be important when we talk about some of the methods for the study specifically, because dexmetomidine significantly decreased instances of agitation, which, dependent on how you define your study parameters, can be considered a form of delirium. So, overall, does dexmetomidine protect trauma ICU patients against delirium? So in this study, we wanted to look at utilization of the drug and if the sedation will reduce occurrence or the length of delirium, will it impact the length of stay in the ICU, and will it improve stability of that trauma patient. And this is something significant, as I mentioned, my personal experience, but just from a hospital standpoint as well, 20 to 50% of non-ventilated patients and 60 to 80% of mechanically ventilated patients will experience delirium. So this isn't a rarity that's only occurring in 1 out of 500 patients. This is happening fairly frequently. So overall approach, we had a retrospective cohort study of patients admitted to the surgical trauma ICU here at CAMC General Hospital between January 1, 2017 and December 31, 2021. Initially, patients must be over the age of 18 and have received some form of sedation following a traumatic injury. Our treatment group received dexmetomidine, and our control group received another sedating agent. So the initial sample size reviewed was 5,000 patients from the trauma registry. However, after review before my involvement, only 194 had actually received dexmetomidine, and then following matching with comorbidities and risk factors, only 144 patients were used following that matching process. So we ended up having 144 cases and 144 controls. Patient data, as I mentioned, was obtained from the trauma registry, and it was using the FIN number, and patient encounters were reviewed in the Cerner Sorian healthcare system. So we had to kick the people out, unfortunately, that were younger than 18 if they were not admitted to the STICU, if their STICU stay was less than 24 hours, if they did not sustain a traumatic injury, they did not receive any sedatives, if they received ketamine during their stay in the STICU, or if they had a medical history of schizophrenia or schizoaffective disorder. However, we welcomed the patients who were over 18, were admitted to the STICU for longer than 24 hours following a traumatic event, and had received at least one sedating agent. So the statistical analyses for the study were ran with SPSS 22.0. The cohort comparisons were done using t-test or Mann-Whitney U-test, and categorical data was run through chi-squared or Fisher's exact. So our preliminary results here, this table is showing our patient demographics and characteristics. Between our cases and controls, everything is pretty even keel until you get down to the intubation category. We did see that there was a significantly higher number of patients that received dexmetomidine that were intubated as compared to the non-dexmetomidine group. Something that I found a little interesting when looking at this, though it's not significant, was there were a higher number of patients not receiving dexmetomidine that were patients of traumatic brain injury rather than patients who received dexmetomidine from traumatic brain injury. I just found that a little interesting because literature suggests that dexmetomidine has a more subtle or lesser effect on the central nervous system compared to other sedatives. So in my mind, I thought that maybe they would have, but I chalk it up for the correlation to physician preference and patient-by-patient basis. The second table is exposure to medications in the STICU, and I see this table having very large implications for the study based on the previous literature that exposure to benzodiazepines increases risk for delirium. So we saw that as far as benzodiazepines and opioids, as well as propofol, there was a significantly higher amount of patients in the dexmetomidine group versus the control group that had received those medications. I associated this a little bit with the fact that there was a significantly higher amount of patients that were intubated, and these medications could have been on board due to the mechanical ventilation, but I can see where this can not alter, but play in with some of the results when we consider that so many of these patients that received dexmetomidine were also mechanically ventilated and also received benzodiazepines, which can increase their risk for delirium. And then this last table here is looking at home medications between cases and controls. At the bottom here, we have some of the examples of the antipsychotics, antidepressants, and benzodiazepines that patients were on at home. None of these proved to be statistically significant. However, we do see overall that the patients in the dexmetomidine group had a higher number or a higher patient number of home medications on board. I tried to see maybe if there were some drug-drug interactions, which is why they might have received dexmetomidine versus non-dexmetomidine sedatives, but again, I chalk that up to physician preference and patient-by-patient basis. So the big question here, was there an impact on patient delirium? From this patient sample, it did not appear to be any association of the rate of delirium and the dexmetomidine administration. Within the treatment group, about 12.4% developed delirium, and within the control group, about 10.4%. And then we talked a little bit about that hemodynamic stability at the beginning with dexmetomidine causing transient decreases in blood pressure and heart rate. So from 170 patients, of the 121 of those sampled, 56.2% of those became hypotensive and 24.6% became bradycardic within 24 hours of the drug administration. And it also appears, correlating with previous literature, that patients are at risk for delirium if they have a predisposure of psychiatric illness or if they had benzodiazepine exposure. So we have our p-values there being 0.01 for psychiatric illness and 0.02 for our benzodiazepine exposure. So limitations of the study: retrospective studies are great because all of the information is there whenever you want to pull it. They're also not so great because some of the information might be there when you want to pull it. Our information that we have is only as good as the documentation that we were provided at the time. So incomplete or tag documentation, missing vitals, incomplete medications, and medical histories can all contribute to difficulties in finding the information that we want to find for these patients. Additionally, we didn't look at the dosage of dexmetomidine. We looked at whether or not it was simply on board. That can be difficult sometimes, looking at the dosages just due to, again, computer error. Maybe it's not inputted there correctly, so we didn't have that in there. Also, we defined delirium or a traumatic brain injury based on the assessment and plan. So if the physician had put it in their assessment and plan, but some may put altered mental status or confusion or delirium or agitation. So how that can be defined can be tricky on what we decide to include or not include as delirium for that patient. And then additionally, something that I thought about while I was going through the study is assessment of patients and whether or not they develop delirium when they're intubated and unconscious their entire time throughout the stay. So future directions: I've had a great time going through the data review on this study. I would be very excited to see further correlations with the comorbidities and opioid use for these patients as they apply to the delirium and the hemodynamic stability. There's never going to be a perfect time where we can say that one thing is absolutely attributed to one drug, especially when these patients are staying in the ICU for greater than 3 weeks, greater than 1 month. They have multiple medications on board. So the best thing here: defining definitive timelines of medication administrations, defining definitive timelines as to when these events are happening, and their admission to the STICU, the discharge, and then their duration of mechanical ventilation. Thank you guys so much. They're my references. Any questions? Yes.
Why was ketamine excluded?
So my answer for that might be different than the leaders of the study, but I've seen that ketamine can induce a certain, its own delirium or a certain form of psychosis. And so my assumption was that we're excluding ketamine simply because it can induce exactly what we want to see. And so we don't want that on board as well. But I think Dr. Kafka is here if he has anything else. Okay, shaking his head no. So anything else?
Any significance? You had a pretty significant hypertension and bradycardia rate. Any significance of any of those? Did you look into that at all?
Are you saying was it significant hypotension or in?
Yeah, it's like 40–50%.
Right.
Clinical sequelae from that.
Yeah, so from my memory when I was going through that, a lot of almost all from what I've seen when I was inputting data experienced some form of a decrease in blood pressure, and then just over that half experiencing the hypotension. And so it was quickly reversed with medical agents, but it was something that was pretty significant, nothing to the point of a hypotensive crisis, but enough that the machine caught it and that kind of thing. So that is, from what I've seen in the literature, just kind of even keel with dexmetomidine administration. I'm not super sure how that would apply to whether or not we're choosing that to be the better sedative as compared to others, just because if it's easily reversed, but it's going to prevent our patients from experiencing this emergence delirium, whether or not where we draw the line on that. I think that's it. Thank you. Okay.
Okay, our next speaker is Frances Salisbury, and she is also a second-year medical student at the West Virginia School of Osteopathic Medicine, and her topic is the ability of the MRI US Fusion prostate needle biopsy to detect clinically significant prostate cancer in a community-based hospital setting. Her mentor is Dr. Dean.
Okay, hi guys. My name is Franny Salisbury. I'm a second year student at WVU, and my principal investigator is Dr. Deem. The resident I work closely with is Dr. Novak, and my senior research associate is Stacy Deschlet. The project that I've been working on is basically surrounded on this technique used for prostate needle biopsies called MRI Ultrasound Fusion. And so we're going to go into a little background about prostate cancer first. Prostate cancer is the second most common cause of cancer-related death in American men. Additionally, about 1 in every 7 men will be diagnosed with prostate cancer during their lifetime. And 300,000 men die worldwide from prostate cancer each year. So early detection of prostate cancer is usually done with a blood screen for this antigen called PSA. PSA is produced by prostate cells. It functions as a protease to break down seminal coagulum to keep semen in a liquid form. Increased PSA detected in the blood can be indicative of prostate cancer or another dysfunction of the prostate. And PSA's levels, they naturally increase with age, but significant increase or rise from an individual's baseline would be investigated further. So in most cases of an elevated PSA, the initial diagnostic procedure involves performing a standard sextant transrectal ultrasound guided biopsy. I'm going to refer to that as a truss biopsy. And they usually take 10 to 12 samples. This is a diagram of kind of what that entails. They use an ultrasound probe as well as a needle. So the downside to using this method is that the sampling technique is often random and may miss significant cancer. This diagram kind of shows that if you take cores from all across the prostate, if the cancer's in a more obscure area, it may be missed. So after having a negative truss biopsy and a patient has a continually rising PSA, this may cause for repeat biopsies and a longer delay in cancer detection. So in recent years, MRIs have been shown to improve the detection of prostate cancer. So a patient with a prior negative truss biopsy and continually elevated PSA may be recommended to have an MRI of the prostate. And then they use this new technology called an MRI Ultrasound Fusion biopsy, which involves taking a patient's MRI of their prostate and overlaying it with a live ultrasound used during surgery in order to create a 3D image to precisely target biopsy cores from lesions or suspicious areas. These pictures kind of show what that involves. They basically overlay the MRI on the ultrasound, and then they can see a 3D image of where the suspicious areas are and specifically target those for biopsy. So once a patient undergoes an MRI, a radiologist will evaluate the scan and assign what's called a Pyrad Score to each lesion based on the likelihood of it being clinically significant cancer. So the score is assigned 1 to 5, 1 being low likelihood, 5 being very high likelihood of cancer. And the score is based on multiple different MRI findings, such as the T2 weighted imaging, diffusion weighted imaging, and dynamic contrast enhanced imaging. It's recommended that a patient receive a repeat biopsy if the lesion is scored of Pyrad's 3+. So Pyrad's 3, 4, or 5 is considered suspicious for cancer. I've included the classification system here, but basically we mainly looked at Pyrad's 3, 4, and 5 lesions. So after the MRI is completed and analyzed by a radiologist, the MRI ultrasound fusion may be performed. This is kind of an image showing how it can be displayed on a screen, live in the operating room. Basically, the MRI image is overlaid onto the live ultrasound. This allows for specific lesions identified on the MRI to be clearly visualized and targeted in real time. In most cases, several cores will be taken from these suspicious lesions, and then also several standard sextant cores will be taken as well. This image kind of shows how you can target areas that are more suspicious using the MRI rather than just taking them from all across the prostate. And so previous studies, including a recent meta-analysis, have shown that using this MRI ultrasound fusion biopsy method has shown a higher rate of detecting clinically significant prostate cancer and a lower rate of insignificant prostate cancer compared to the trust biopsy. So they define clinically significant prostate cancer as a Gleason score of above 7, and this technique of MRI ultrasound fusion has been implemented here at CAMC beginning in January of 2016. And then this is kind of just an overview of what the process looks like for most patients. A patient might come in with an elevated PSA value. They have a standard prostate needle biopsy or a trust biopsy. That might turn out negative. You keep watching them. Their PSA continues to rise. They might have an MRI. The MRI could then lead to an MRI ultrasound fusion biopsy being performed. Clinically significant cancer may be detected, and then treatment or active surveillance may ensue. So our study, the specific aim was to look at how this MRI ultrasound fusion technology has been implemented here at CAMC and see if the results coincide with consensus on the management of patients and how these results differ from the typical trust prostate needle biopsy. So methodology, our study design was a retrospective chart review with patients who underwent a prostate MRI and subsequent MRI ultrasound fusion prostate needle biopsy here at CAMC from January 1st of 2016 to June of 2022. We collected all kinds of data, anything from demographics all the way to like outcomes. Some of the most important things we collected was the history of a prior prostate needle biopsy before their MRI ultrasound fusion biopsy, how many cores were taken, how many of those cores were positive, the Pyrad score of their MRI, and as well as follow-up data. And so we use t-tests for categorical variables, multiple regression analysis for continuous variables. And then the results that we have, so we found that there was a total of 211 patients that had an elevated PSA and then had a Pyrads of 3+ on their MRI. 91.4% of those cases that had the Pyrads 3+ lesion were found to be positive for prostate cancer. And then of those that were positive for prostate cancer, 67% had a grade 2 or higher cancer. So they were finding high-grade cancer in 67% of those cases. 111 out of 211 patients with the Pyrads of 3+ lesion on MRI had a prior negative trust biopsy. So about half the patients had had a prior biopsy that turned out to be negative. And then out of those that had a prior negative biopsy, 83% of them were found to be positive with the MRI ultrasound fusion biopsy. Okay, and then this is out of the patients who had a Pyrads of 3+ lesion on MRI. The blue is just showing approximately how many patients with the prior negative trust biopsy who were also negative on the MRI ultrasound fusion biopsy. And then the red is showing patients with a prior negative trust biopsy who were then positive on the MRI ultrasound fusion biopsy. Okay, and this is out of all patients who were positive for prostate cancer using the MRI ultrasound fusion biopsy method. 7.73% of them had a Pyrads 3 lesion, 36% had a Pyrads 4, and 55% had a Pyrads 5. And then this is looking at individual Pyrad scores. So this is all patients who had a Pyrads 5 lesion. 92% of them were found to be positive for clinically significant prostate cancer. This is for Pyrads 4. 79% of them were shown to be positive for clinically significant prostate cancer. And then same for Pyrads 3, 75% of them were found to have positive clinically significant prostate cancer. So what can we conclude from all of this data? MRI ultrasound fusion biopsies have shown to be an efficient method for detecting prostate cancer here at CAMC. The results showed that clinically significant prostate cancer was often detected on MRI ultrasound fusion biopsies even after the patient had a negative trust biopsy. MRI ultrasound fusion biopsy is a more sensitive test for detecting prostate cancer that could otherwise be missed with the trust biopsy technique. And better detection and earlier treatment initiation can lead to improved overall health outcomes for the patient. And then additionally, MRI and the Pyrad scoring of the prostate has shown to be effective and accurate tool for predicting clinically significant prostate cancer, even in patients with no previous biopsy. And so why is this significant? Basically, it's been a large issue managing patients who have a negative prostate needle biopsy, but their PSA tends to keep rising. And so this is a good tool to understand how to manage those patients in the future. The MRI Ultrasound Fusion prostate needle biopsy of suspicious lesions is a new technology, has proven a higher rate of detecting clinically significant prostate cancer, and our results from the use of this new tool at CAMC can help help guide our future management of men in this patient population. These are my references, and I can take any questions if you have any. And if not, thank you guys so much for your time. Oh, wait. Yeah.
Thank you for a nice presentation. Did all of the trust, you took all patients, I'm sorry, on the design, all the trust negative then went for the fusion, is that correct?
Yeah, not all patients who had a negative trust biopsy then went for the fusion. We basically took all patients who had the fusion biopsy and looked at which of those had a negative trust before they got the MRI fusion. Yeah. Okay, thank you guys for your time.
Okay, thank you. Our next presentation is from Claire Drotman, and she is second-year medical student at the West Virginia Osteopathic School, and her topic is evaluation of antimicrobial stewardship when using Biofire Film Array Pneumonia Panel, and her mentor is Dr. Kafta and Dr. Robinson in the pharmacy schools.
What do I hit to? Click your name. Oh, my. Alrighty, hello everyone, and thank you. My name is Claire Drotman, and I'm a second-year medical student, and today I'll be presenting to you on the evaluation of antimicrobial stewardship when using Biofire Film Array Pneumonia Panel in trauma ICU patients. And again, I just wanted to express my gratitude and thanks to Dr. Robinson, Dr. Kafka, Dee, Melda, and Stacy for all of their help throughout this process. So infections are the leading cause of late mortality in trauma in patients with severe trauma, and pneumonia is also the most common major infection in trauma ICU patients. And this is due to all the risk factors that the trauma ICU population is subjected to, with the most prominent and most primarily being mechanical ventilation, and I kind of listed a few over there, as you can see. And so for this reason, the early recognition of pathogenesis and timely, appropriate, and effective antibiotic therapies are crucial for the diagnosis and treatment of pneumonia. And so currently, our gold standard for detecting pneumonia, the pathogens that cause pneumonia, is a sputum culture. And so the turnaround time for this is usually with a negative result, it will take about 24 hours, and a positive result can take anywhere from 48 to 72 hours. There's also some problems and challenges with sputum cultures in that they're problematic for identifying viral pathogens and fastidious bacterial species. Recently, we have a new type of powerful tool called the Biofire Film Array Pneumonia Panel, which is essentially a PCR device that allows you to detect 33 different targets in only 75 minutes. And that includes 18 different bacteria, 8 viruses, and 7 resistance genes. This also is advantageous compared to a sputum culture because multiple studies consistently have shown it has a higher sensitivity and higher specificity. It also is advantageous in that it can simultaneously detect both bacteria and viruses in a single PCR run. It also is able to detect bacteria that are difficult to grow on sputum cultures, and it provides you a semi-quantitative estimate of abundance. And so now shifting focus kind of to antimicrobial stewardship. And so the whole basis behind antimicrobial stewardship is the idea that when you have faster and more accurate results, you'll be able to quicker implement the appropriate antibiotic therapy, thus leading to decreased C. diff rates, side effects from overtreatment, mortality from undertreatment, and also the length and cost of a hospital stay. And right now, which one thing I thought was interesting was that to our knowledge, there are no current studies that examine the real-world utilization of the Biofire Pneumonia panel as an antimicrobial stewardship tool in only the trauma ICU patients diagnosed with pneumonia. And so right now, just to kind of recap, so what we know. So we know that the turnaround time of sputum cultures is a limiting factor for the timely diagnosis and targeted antimicrobial treatment. We also know that the Biofire Film array has a higher specificity, higher sensitivity, and faster turnaround time. And so it has this big potential to improve our antimicrobial stewardship outcomes. And so therefore, what we want to know. So our primary objective was we wanted to know, is the pneumonia PCR being utilized efficaciously by physicians, thus leading to positive antimicrobial stewardship outcomes at CAMC? Secondly, we also wanted to know, is there a difference in time to appropriate antimicrobial escalation, de-escalation, or discontinuation when using the pneumonia PCR compared to a sputum culture? And lastly, we wanted to look and see, is there a difference in C. diff rates comparing sputum cultures versus the pneumonia PCR panel? And so shifting gears over to our methods. And so this was a retrospective case-controlled observational study that ran the length between September 1st of 2017 to August 31st of 2021. And so our first group was our control group, and so they received a positive pneumonia diagnosis via a sputum culture. Then, in August 26 of 2019, CAMC implemented this new technology called the Biofire Pneumonia PCR panel. And so from August 26, 2019 and on, our study group or our experimental group was those who had a positive pneumonia diagnosis using the Biofire Pneumonia PCR. And as you can see, our control group, we had a total of 103 patients after different exclusions, and our study group, we had 47 patients. And our performance site, and so while our IRB protocol stated that we were at General Hospital Memorial and Tees Valley, which are affiliated with CAMC, this particular study only looked at the General Hospital because that is where our level 1 trauma center and our trauma ICU population is located. And so our inclusion criteria was that you had to be over 18 years old, diagnosed with pneumonia, and admitted to the trauma ICU. Our exclusion criteria is a little more lengthy. I just wanted to highlight a couple. And so, for example, one of them is patients that demised or expired within 48 hours of their hospital stay, or if by the time their culture results came back, if they demised and the physicians didn't have the chance to adjust the antibiotics. And again, patients that were placed on comfort care and meds were removed before we could possibly make a change to the antibiotic regimen were also excluded. And so we collected a lot of data. A lot of it can be used for future studies, which is great. And so, like I said, we looked at sputum cultures, the Biofire PCR, the viral respiratory PCR, and then we looked, what was the method of collection? Was it positive or negative? And then we looked at all the possible bacteria and viruses that came up positive. We also looked for different urinary antigens, and then we looked at the antibiotics, which ones were given and how long they were given throughout their entire hospital stay. We wanted to see, was C. diff diagnosed throughout their admission, and did the physicians request an infectious disease consult? And so the first thing I did, so if we're looking at our control group, the first thing I wanted to see when I was looking through the records was a sputum culture ordered? And if the answer was no, then that patient was excluded from the study. On the contrary, if the answer was yes, I would say, okay, was it positive or negative? What organisms were isolated? And then I would record when the culture was collected and the earliest complete microbiology report of the listed specimens. And then for our study group, I essentially did the same thing, but instead looked at the pneumonia PCR panel. And so again, if there was no pneumonia PCR panel, that patient was excluded from the study. And if yes, I recorded the date and time that the results were published. So the next step was determining the indication for antibiotic use. And so pneumonia can be broken up into 3 different categories. We have CAP, which is community-acquired pneumonia. And to be considered CAP, the sputum culture or PCR must be obtained less than 48 hours from inpatient admission time. On the contrary, we have HAP, which is hospital-acquired pneumonia, and that's when the sputum culture or PCR is obtained greater than 48 hours into their hospital stay. And then there's ventilator-acquired pneumonia, which we call VAP, and that's a little more complicated. So that in order to be considered a patient that got VAP, you would have to be on mechanical ventilation with which was delivered via an artificial airway for greater than 2 consecutive days. And if a patient, let's say, was extubated and there was 1 full calendar day, 24 hours, and then they had to be re-intubated for whatever reason, we have to restart that count. And I also wanted to just take a minute and highlight that we have certain pathogens that are more commonly seen with community-acquired pneumonia versus hospital-acquired pneumonia, but there's also a mix of the two, and which is why it's important to look at those times and look when these sputum cultures or PCRs were collected. And as you can see in blue over there, anything in blue is kind of cross. It could be potentially CAP or potentially HAP. And so right now, CAMC, this is the CAMC recommended antibiotic therapy for patients diagnosed with pneumonia. I'm not going to run through all of them. The ones in colors just show that there's certain bacteria that you can choose options. You have options. One thing I did want to highlight is that if the results are negative, our CAMC recommended guidelines say that you can either discontinue the antibiotics if you no longer suspect pneumonia, or you can place the patient on ceftriaxone monotherapy. But the next step I did was we evaluated the antimicrobial stewardship. And so this was divided into appropriate versus inappropriate. And so with negative results, something was considered appropriate if either no antibiotics were given or the patient was placed on ceftriaxone monotherapy. On the contrary, the negative result was considered an inappropriate decision if there was either overtreatment with antibiotics or unnecessary treatment with a second-line antibiotic. Then, for positive sputum culture or PCR results, the action of the physician was considered appropriate if the bacteria was susceptible to the prescribed antibiotic and adheres to the CAMC recommended therapy guidelines, and considered negative if either no antibiotics were given, the bacteria was not susceptible to the prescribed antibiotic, or if there was a delay in starting the appropriate treatment. And so these were all categorized in continuation, discontinuation, escalation, and de-escalation. And so essentially we had 8, right? So for continuation, we had appropriate continuation and inappropriate continuation, and that continues for the rest. And so essentially, if a physician suspects pneumonia, they're going to place a patient on an empiric antibiotic therapy, and then once the results come back, then based on those results, they will decide what to do. And so, for example, let's say they place a patient on a broad-spectrum antibiotic and it's Pseudomonas, and they place them on Zosyn. Well, our recommended therapy for Pseudomonas is to keep them on Zosyn, and so that would be considered continuation. And we documented that as the time is equal to 0. And so that was our quantitative value. For discontinuation, the quantitative evaluation of this was from the time that the results were published until the time that the physician put in the discontinuation order. And lastly, for both escalation and de-escalation, we quantitatively looked at this from the time that the results were published until the time that the physician put in the new antibiotic order. And this is important and keeps things consistent because in nursing, once a physician puts in an order, the nurse usually has like an hour before or an hour after to give that medication, and so we felt this was the most standardized approach. And one thing new to me with antimicrobial stewardship was the concept of escalation and de-escalation, so I wanted to take the time to explain that to anyone who's unfamiliar with this concept. And so as you can see, I have a whole spectrum of different antibiotics, and some are more narrow spectrum, meaning that they target specific bacteria, versus a more broad spectrum antibiotic that can target a larger range of bacteria. And so when we use the term de-escalation, we mean that physicians are going from a broader spectrum antibiotic like Zosyn to something more narrow spectrum like azithromycin. And on the contrary, when I say escalation, that means we're going from something more narrow like cefazolin to something more broader like meropenem. And so looking at all of our results, again, I just wanted to show that our primary objective was, is the pneumonia PCR being utilized efficaciously by physicians, thus leading to a positive antimicrobial stewardship outcome? Move this. Sorry. And so we determined our statistical significance with a p-value of less than 0.05, and we used the SAS 9.3 software, and the comparison of categorical variables, we used contingency tables with chi-squared, and for continuous variables, we utilized ANOVA. And so I kind of broke it up into looking at appropriate first, and then we'll go on and look at inappropriate. And so as you can see, for appropriate, we have in the light blue box, that's going to be our control group prior to 2019. So that's our sputum cultures, and in the dark blue box, that's going to be our experimental group using the Biofire Film array. And so we did see a statistical significance of positive antimicrobial stewardship outcomes with appropriate escalation in the Biofire PCR compared to a sputum culture. On the other hand, when we looked at the inappropriate side of things, we didn't see any statistical significance or improvement in the inappropriate therapy when using the Biofire compared to a sputum culture. And I thought that was interesting, right? And so what does this mean? Well, it could be due to the presence of antibiotic-resistant bacteria that are not susceptible to the recommended antibiotic regimen, or maybe it's just that physicians are not prescribing the optimal suggested treatment decisions, right? Because I kind of figured, oh, maybe we would see some improvement in less prescribing in inappropriate therapy, but we didn't see that. Our secondary objective number one was we wanted to then look at, is there a difference in time to the appropriate antimicrobial escalation, de-escalation, or discontinuation when using the pneumonia PCR compared to sputum cultures, right? Because our sputum culture can take 48 to 72 hours to come back, but our pneumonia PCR, we get it back in 75 minutes, we get our results. And so these were all measured in hours. And so as you can see here, we did see a statistically significant difference in escalation time. And so as you can see for sputum cultures, the average was around 27 hours versus the Biofire PCR, which was an average of around 10 hours until the physician escalated or de-escalated or changed the medication. Next, we wanted to see, okay, is there a difference in C. diff rates in the pneumonia PCR compared to the sputum culture? And we did not see anything. It kind of was similar. And with C. diff, that's a common side effect of overtreatment. And so there really was no significant difference. They were around the same. And so heading into our discussion, right? So although the Biofire Film Array panel is a powerful stewardship tool, our results demonstrated that we saw statistically significant increases in only appropriate escalation, and there was no difference seen in all other results, right? And so why is this the case? Again, maybe due to delays in placing orders to change a patient's antibiotic regimen after the PCR results have been published, not adhering to CAMC recommended antibiotic therapy for the treatment of pneumonia, or maybe it's just due to our limited sample size, because we did only have 150 patients. And so from all this, I kind of took away that rapid diagnostic techniques are not as impactful when physicians do not adhere to stewardship policies. And so our project did have some limitations, and the analogy I like to use is our pneumonia treatment protocol is very black and white, right? If this bug, give this medication. But the reality of the trauma ICU population is the situation is often very gray, and I'm very thankful that I had Dr. Kafka to help me with that, because we ran into some, like, what's going on here? What's going on here? And we really had to look and figure out what was going on, and that's because a lot of these trauma ICU patients have various different comorbidities. And so we didn't exclude for bacteremia, we didn't exclude for fungal infections, or maybe chronic conditions that may have altered or changed the decision of what either infectious disease or the physician wanted to put the patient on. Also, there could have been a presence of antibiotic-resistant bacteria that were not susceptible to the recommended antibiotic regimen. One thing that I thought of, for example, like I said, we wanted to keep things consistent, and so I remember when I was doing our chart review, we had a particular patient who 3 weeks into their stay got diagnosed with pneumonia, and it came up positive for Klebsiella. And so the treatment decision for Klebsiella is ceftriaxone, and the physician chose a different medication. And while I was reading and snooping through the notes, I came across a little sentence that said, patient had already completed a 7-day treatment of ceftriaxone, and so we're using this medication instead. And so realistically, in the real world, like, okay, maybe that second line approach is the correct decision, but for standardized procedures, that was considered, inappropriate to keep things consistent. And again, sample size could have been an issue as well. And so some future direction is, and just some questions that I had, and that maybe what we can take away from this study is that, are some physicians still waiting for the culture results to return despite having the PCR results, right? What is the holdup? What's taking so long to escalate or de-escalate or change those medications? Why aren't physicians adhering to the CAMC recommended antibiotic therapies? Should we re-examine the most up-to-date literature and our current guidelines for the treatment of pneumonia? Like I said, our treatments are pretty black and white, and the reality of the situation is it's not always like that. And can we maybe broaden our recommended treatment options for patients with comorbid infections? And so our results again demonstrated that we need to provide more education to our trauma ICU physicians on antimicrobial stewardship in order to best utilize this new powerful stewardship tool. And just some final thoughts that I kind of came across when I was looking through the data, and I just kind of wanted to bring this up, and I felt that they were maybe a good topic of discussion to discuss with our trauma ICU physicians is, like, why are we continuing doxycycline or azithromycin with ceftriaxone when the PCR sputum culture results are negative, right? And so commonly I would see, okay, they would put them on the ceftriaxone and the doxycycline, but when the results came back negative, instead of DCing one of those orders, they would continue both. At the same time, why are we consistently continuing either cefepime or Zosyn empiric therapy instead of de-escalating? Often, again, they would put cefepime and Zosyn are very broad spectrum antibiotics. And so once the culture results came back, it was often that the physicians would just continue these and not change the antibiotic regimen. And lastly, what are the reasons for selecting these antibiotics outside of the recommendations being utilized? So for example, ceftaroline, right? That wasn't one of the medications or antibiotics that was listed on the recommended therapies, but I would often see that medication being used in the treatment of pneumonia. And so is this due to failure of other agents? Was this recommended by infectious disease as it is a restrictive agent at CAMC? And just some kind of like thought-provoking discussion for some future direction. And these are my references. And again, I just wanted to thank everyone who helped me with this project this past summer. It was a lot of fun and I really learned a lot. And does anyone have any questions? Yes?
If this new technique is so great, why don't they use it as standard of care? Is it more expensive than just regular sputum cultures?
Yeah, that's a really great question. And when I was reading the literature, I think it's because this technology is so new and we're so set in our stones of sputum culture. But I found so much research, like all these studies showing that that this Biofire is so much more powerful and has so much benefits to a sputum culture. And I kind of wondered the same thing, like when are we gonna, take that next step? And I'm like, are physicians, are they not comfortable with changing the antibiotic regimen until the sputum cultures come back? One thing I also thought was really interesting was that so there are tons of studies out there showing, again, Biofire is better, has a lot of advantages compared to a sputum culture, but I only found 2 studies that took that next step that we did here at CAMC and looked at our physicians and critiqued, what are our physicians doing? How are they utilizing this new technology? And in fact, the only 2 studies I did find, it was like one of them had 30 patients, the other had 14 patients, none of which, it was all just generalized ICU. And so I thought that was really interesting that CAMC, was taking that next step and doing that.
Did you see any difference on the demographics of the patient, like if they had insurance or not? Well, like patients that had insurance, they used the Biofire, or patients that didn't have insurance, they just used the regular standard. Did you see difference in that?
Yeah, so we didn't really look into the insurance methods. It was kind of just like after 2019, Biofire. Prior to 2019, sputum culture. Yeah, it could be. Yeah, definitely.
The expense of ordering this test might be why the physicians are being so like, I'm not going to do this because the patient's going to suffer or the hospital's going to suffer.
Yeah, that's a great point.
Is there any new data, I didn't hear length of stay, maybe in the ICU or total length of stay, it doesn't sound like you looked at that, but maybe any of the studies that you reviewed, is there a shorter reduction in the length of stay, either in the ICU or the total length of stay that you used?
Yeah, so we did collect that data, but we did analyze it, and hopefully it can be used for future studies. In the 2 studies that I found that was looked at in the trauma ICU population, they did not look at the length of stay. They just kind of looked at the continuation, discontinuation. But that is another thing that we can take with this data now that we have it and look at that as well. All right, thank you so much. was for questions.
Okay, our last today is Caleb Duncan, who is a second-year medical student at the School of Osteopathic Medicine, and his study is a qualitative phone survey of patient experience with providers, looking at contributors to health to HCAS, which is our patient experience survey tool, and looking at those ratings. This is a really different study here, bringing up our last topic for today, and his mentor was Andy Tanner in family medicine.
Can I click this on?
Yes.
Okay.
Yeah.
Okay, so I'm going to click this on. Can everyone hear me okay? All right, perfect. All right, so good afternoon, everyone. My name is Caleb Duncan, and today I'll be presenting my research on a qualitative phone survey of patient experience with providers, and these are contributors to HCAHPS ratings. So when you see that acronym, that is what we go by as HCAHPS. So don't be confused if you see that acronym anywhere. My principal investigator for this investigation was Dr. Andy Tanner, and my research coordinator was Lisa Calderwood. Our primary aim and objective of this study was to determine what contributing factors resulted in specific HCAHPS scores related to patient experience with their providers. In terms of the background, I know a lot of you may not be familiar with this if you're not in a hospital setting, and I was unfamiliar with it prior to coming and doing this research. So what essentially HCAHPS is, it was developed in 2002 by Medicaid and Medicare, and this was to really standardize and publicly report surveys of patient experiences with their hospital care. So this really set a new tone and standard across the nation of how those patient experiences are going to be rated on. And this also was publicly reported to the patients as well, so they could analyze different hospitals in their state versus other states and see, oh, is this a hospital that I want to go to or may not want to go to? This was also the first national method of collecting data, measuring patient satisfaction with their care received at the hospital. And the survey is comprised of 27 questions, all related to the aspects of patients' experiences at the hospital. So this can range from the cleanliness of the hospital, which does end up impacting scores. One of the patients that I talked to rated the hospital low because there was a Cheeto in the floor for 3 weeks, and he didn't appreciate that. So that was one thing that can definitely impact, as well as the staff friendliness, interactions with their doctors, anything of that nature, all is included in the survey. In terms of what does HCAHPS not tell providers, there is absolutely no feedback related to the patient's experiences with their providers. So for example, one of the questions that is on the survey is it'll ask, did your provider treat you with courtesy and respect? And they'll fill out always, usually, sometimes, or never. And they'll just simply check that box, and there's not really any comments left unless at the end of the survey, the patient will end up writing a specific comment about their provider. And then I thought this was interesting too. According to a recent study, physicians tend to misjudge the success of their communication skills in interpersonal exchanges by considering their communication suitable while their patients are thinking otherwise. So it's really important to see how we can improve those outcomes and experiences with patients and recognize those differences and things that they would like to see from us. In terms of the significance, this has immensely huge financial implications. And the reason for this is because Medicaid and Medicare will often withhold funding if a hospital is not performing up to standards from patient experiences. So say you have a really good hospital that is making really, really good patient experiences. They'll end up giving more funding for that hospital, whereas a hospital performing in not so good areas may receive less funding. And in terms of that criteria, patient experiences compromise 30%, and that's something that they use for this HCAHPS survey. And then also, effective communication has been shown to lead to increased patient motivation, so they're really excited about their care. They really want to take that initiative, take that next step to improve their health outcomes, and that often leads to treatment plan adherence as well. In terms of the methods, this was a descriptive qualitative study conducted by the phone. I used the same phone in one of the offices here at the Sherry Building, and it also dialed out as a CAMC number, so that may be why we got some good response rates, which you'll see coming up. And then all the questions are open-ended, and I really wanted to highlight that because we didn't want to promote a specific answer from the patient or guide them into giving us a specific adjective or way that they would describe their physician. And then so how I was able to do that was I would ask, okay, how did the provider treat you with courtesy and respect? Can you tell me about that experience? And that's what I would ask them. And then one question was asked about each of the 3 HCAP questions solely related to provider experience. In terms of the study population, this consisted of the most recent 100 participants who provided their contact information at the end of the HCAP survey. So they actually provided their phone number to be contacted from us, and then that may have some implications coming up as well. And this was completely randomized as well. I wanted to provide you with my phone survey script that I went by. I'm not going to go through all this. It may be a little difficult to see as well, but I wanted to highlight that as soon as I got on the phone, I said, "Hi, my name is Caleb Duncan," and I think by doing that, it really got their attention because I was afraid that they were going to think I was a telemarketer and I was going to immediately be hung up on. So I wanted to really get that out of the way right off the bat, and then I also wanted to say that I was working with CAMC as well. So maybe that may have some implications of why I got good responses too. In terms of the data, this was a combination of existing CAMC HCAP data and also the results from my phone survey. And then we collected demographic information on the gender, the age, hospital location, the service type, and overall hospital rating. And this was question 18 on HCAP survey. The statistical program SAS was also used to analyze the data. And in our protocol, we did list that we're going to use chi-squares and appropriate Fisher's exact test and means and standard deviations, but for this presentation, I'm solely going to be focused on our responses to open-ended survey responses and categorize them and summarize as qualitative findings, because there are a lot of variables involved in this. In terms of the sample size, we had 72 consent out of 106 patients, is what I called. We originally started with 100 patients, but some of the numbers were disconnected or no longer in service. So we requested an additional 10 numbers from the IRB. So that's why overall we have a sample size of 110. And like I said, 68% consented to the survey. However, as I was going through, one did end up hanging up on me. So that number is going to be 71. And then 18 people simply just didn't answer the phone. This is results for question 1, and this was related to asking them the question, how did your provider treat you with courtesy and respect? So I'm not going to go through all these variables, but I do want to highlight the top 3 as I think these are really important to consider. So out of those 71 participants that we had, around 38 participants said that they value their doctor's efficiency. So anything that was, did the doctor spend enough time with you in the room, that fell into that category. In terms of following the top 3 was kind and friendly, and then rounding out not so much of the good results was not spending enough time with them, speaking over, and rude. And we didn't have that many bad responses, which is something that I think CAMC should be proud of, and we'll undergo that investigation as well. We also, during this question, this first question, we looked at males and females' responses and see if there was any differences. It should be noted that we didn't do any statistical analysis on this to see if there was any exact statistical differences, but we may suspect that these may be what males and females are looking for in terms of courtesy and respect with their provider. So females rated that their physician was kind 29.7% of the time, whereas males only said 14.7% of the time, and also females rated respectfulness as 27% of the time versus males at 14.7%. In terms of male responses, some of the differences that we noticed was males valued maybe knowledgeable providers at 11.8% in comparison to females 5.4%, and then professionalism was a great number of 29.4% in males in comparison to females 5.4%. In terms of question 2, this was asking if the provider listened carefully to them. So I'm going to go over the top 3 variables here as well. So the first one is answered questions. Around 31 participants said that, followed by listening to the needs and concerns, taking time, and being attentive and showing interest. And what I found from the feedback from the individuals when I was speaking to them on the phone, they really wanted the provider to sit down, have a conversation with them, look them in the eye, show interest in their conversation, show interest in those questions. So I think that was something that we can always improve on and maybe take notice here at CAMC as well. And it seems like we're doing a pretty good job. In terms of things that didn't go so well, some patients said they were being rushed, they didn't experience any contact. Sometimes the physician may be dismissive or just typing on the computer. And I thought that was interesting because sometimes as a doctor, we like to get those soap notes done and we're sitting there typing on the computer and maybe we need to maintain good eye contact better. In terms of question 3, this was related to providers explaining things in a way that the patient could understand. So overwhelmingly, 54 participants said that the provider explained in a way that was familiar to them. So anything that fell in this category was, did the provider explain things in a way with layman's terms? Could they understand it? Anything of that nature we placed into that category. And then I also thought this was interesting was patients for clear instructions preferred written instructions. So verbal instructions they often forget, and I think that is something that we need to consider is, yes, discharge instructions and clear instructions, even in family practice, if we can write down specific medications when to take, when not to take, that can mean a big difference in a patient. In terms of, on the flip side, some bad responses that we had was they simply had trouble understanding, whether it be medications, instructions, procedures. Some of those things could be improved on, and maybe one thing that we could do is ask the patient if they could explain the procedure to us, so we can fill in those gaps. Question 4 was related to video-based instructions, and this was looking to see if the patient received any video-based discharge summaries or instructions. And some of them said that they did watch some videos in the hospital, some said that they did receive video-based instructions, and then some just said that they received written instructions, overwhelming the majority. Question 5 was any problems related to records being sent to their PCP. We only had 1 or 2 patients that really had this problem, so I sent these issues to my research coordinator, Lisa, and she took care of that as well. And then in terms of question 6, this was any recommendations for improvement with provider communication. And this is something that we really was hoping to get good response rate, but unfortunately we did not. So one thing that may have affected this is it was the last question on the survey, so they may have said, okay, I want to get off the phone with you, I'm done taking this survey, and that may have some implications there. And the second thing is maybe they just had a really good hospital experience here at CAMC. So those are 2 factors that may implicated those results. In terms of things that we did hear back was slowing down, explaining medications better, being nicer, and just improving follow-up care. All those things did impact care and the HCAHPS rating. One thing I also want to talk about is an experience that I had on the phone with a patient, and this patient was nonverbal. So he had his daughter there with him speaking for him, and it was really sad to see that he had poor hospital experiences. So he said that providers sometimes didn't understand what he was saying, or they would rush or just come out of the room real quick because they couldn't really understand him. So that's maybe something that we could look at as additional training with speaking with nonverbal patients here at CAMC. This was the participant information. So our overall population was 106 with 71 participants. In terms of the overall rating, our population size had an overall rating of 8.95 out of 10, whereas my participants from the phone survey had a 9.11 response rate. And something that I really wanted to look at was this overall rating, because that may be why we got people to answer the phone, because they were able to provide their information to us to be contacted. And I think that may be why we got so many people to answer the phone. In terms of males and females, we had a 50-50 split on both studies. So I thought that was interesting, and that may be representative of the true population size in terms of gender. And then our overall age was 66 for both studies around that. And then these are just the facilities listed, the statistics on that as well. In terms of the conclusions, we may and can suspect that females may place more value on kindness and respect versus males' importance on professionalism and knowledgeable providers. And the main thing about this is that it offers us insights into patient and provider communication. And that is something that is really, really essential, and how we can improve, how can we see what we are doing good, and how we can continue to do those things. What are patients really looking for out of the provider? In terms of things that we suspect that providers can be improved on is slowing down, not being in a rush, not dismissive of the patient, and just simply explaining things better. And then more studies analysis should be conducted to investigate these suspicions. So how can we get honest feedback from patients who are dissatisfied with their provider hospital experience, as our population is only comprised of patients who opted into receiving phone calls? And another future direction that we may take is some of these participants did have some recall bias, so they couldn't remember their experience that they had at the hospital as a survey was completed 2 or 3 months ago. So I think that may be something that we may look into is at the time of discharge in the future, if we can ask these questions more open-ended and see if they can give us better responses on that. These are my references, and at this time, I'd like to take any questions, and I'd like to thank Lisa for everything and Dr. Tanner. Okay. All right, Audrey.
Thank you for your presentation. I have a quick question. I was curious, why did you guys do a statistical significance on the results?
So Lisa could explain that better, but there was a lot of variables involved, so I'm going to let Lisa take this one.
Sorry, I was curious why you guys did do a statistical significance.
I attempted to do some analyses, but I would have needed to collapse some of those variables. So because there were open-ended questions, I would have to collapse some of those options to make it look for some significance. And it was more informative to leave it as it was. So.
Okay, Dr. Rubin.
I'm not sure I missed this at the beginning, but of the people that you sampled, how many said that they had actually received the HCAP survey to complete? And of those, how many actually completed it?
These are all people that received the survey, returned it, and had filled in their name and phone number as an opt-in to be contacted.
Yeah.
So they agreed to be contacted?
Yep.
Thank you.
So Hill.
So one of the conclusions that you made is that based on the results, physicians could consider slowing down, not be in a rush. Wouldn't that, in a consequence, lead to other patients possibly waiting longer for that physician to attend them?
Yes, so that is another point that could impact results, but also we want to ensure that the patients do have good experiences and we don't want them to feel like they are rushed. So we want to mainly give the best care that we can. So maybe we have more providers on hand at that time in the hospital for certain surgeries or something, or just having someone come in and speak to them and listening to them, offering them water, offering them cups of glass. So I think any of those, I mean, not glass, but ice. Anything of that nature, yes. All right.
I think you made a really good comment in the very beginning, and that is sitting down and having eye contact. And that doesn't take any, delivering the message when you're sitting and having eye contact takes no additional time than it does when you're standing. And unfortunately, some of our rooms are old, and our computers are here, and our patients are here. So also what you said about, trying to get the note, get the work done, when the design of our rooms makes it very difficult. Our older rooms, our newer rooms are more friendly to that, and the computer's here and the patient's here. So those are some strategies I think you brought out, that the simple things that really don't take extra time.
Yep.
And leave the patient with a different perception of how well the communication took place.
Yep.
We should all learn from that, sitting down now. It really doesn't take more time.
Yep.
Do you have a question, Robin?
Yes, Elaine, and just quantitatively, from a time perspective, we probably don't have how much time the physician actually spent in the room. Is that true?
No, we don't have that time available.
So, building on what you said, I think the perception, somehow, if we don't have that number, the perception that the patient feels that you're giving him or her adequate time is something to kind of reflect on versus the absolute time. It may not be the time, but somehow maybe the body movements that you make.
Right.
Interact with that patient, they feel like they've been rushed.
Right, exactly.
Interesting study.
Thank you. Any other questions?
I was just going to say, great job. Look at them all. I need to ask the externs to stay around. We need a class time.
Okay, before we sign off, I just thought of 3 things that I need to say. One is I wanted to say that one of the deans from the osteopathic school is with us today, Dr. Art Rubin. And I didn't want to say that at the beginning because I didn't want anybody to be scared. That's at the osteopathic school. But thank you for being with us. We appreciate it very much. I want to thank Robin Rector once more again, She's retiring after 40 years. Tears. So she's her last class. And I want to say thanks again for letting me substitute for Dr. Jubileer. I know he would love to be here. His heart and soul is here. And if he were here, he would be saying, have a magical day. Thank you. Did you want to say something, Rob? I did. Elaine wants to have the last hurrah. I do.
We definitely appreciate any feedback that you can give us. And please don't think that if you tell us something that sounds negative, we do not take it that way. We take what you say and maybe help provide a better experience the next time. So please feel free to, you can contact your coordinators, or you can contact Mary or me. We won't tell on you or anything like that. We will take those things to heart. What were the most challenging things about your rotation, and what were the best things, so that we'll know and we can replicate that or do something a little different last time. I think some of the goals of this are we cram a lot into a short amount of time, and it's almost a whirlwind 6 weeks that you're here. But one is to give you an overall idea of what the research process is like, and that it's complicated. And when you start reading articles and critiquing articles, you'll have a much better understanding of what it took, and maybe look at those with a more critical eye than you would have otherwise. And the other is learning from each other, and this is the perfect opportunity to do that. I hope you leave here today learning not just what you did about the in-depth information about the subject that you studied, but the in-depthness of what everybody studied. I mean, I learned things when I come to these, and this was a really, really good class. I commend you all for the good work that you did. Thank you.